All right, thank you, Larry, for the introduction. Good evening, everybody. My name is Yenh. I am the program administrator for the Nevada Prescription Monitoring Program at the Board of Pharmacy. I know it's late now. It's probably, for some of you, it's your bedtime, like myself. So I'll try to make this as painless as possible. And hopefully the hour goes by quickly without you falling asleep. So without further ado, I'll just go ahead and dive right in. I do want to point out I do not have any kind of conflict of interest to this presentation this evening. So the topic of interest tonight, it's been what everyone has been talking about, and that is our ever-growing problem that we are facing as a nation, and that is the prescription drug abuse. It's in the media now and in the news, and President Obama in February of this year proposed to spend $1.1 billion to fight the problem. And there has been new guidelines out from the CDC to tell you how to manage pain. And in Nevada itself, we've actually, there were some laws that were passed last year to help with the problem. And I'll go into details about those Senate bills that were signed into law. And lastly, I'll talk about the PMP and how we can utilize the PMP to find patients that may be abusing controlled substances and help them get the treatment that they need. So the United States, we have about 322 million people. We make up about 5% of the world's population, yet we consume 80% or more of the world's supply of opioids. That's a huge percentage. Now that's 75% of the world's supply of oxycodone and 99% of the supply of hydrocodone. All right, we're using massive amounts of these drugs, and we're just a small, population compared to the whole world's population. How did we become this nation so dependent on these narcotics, on these medications? As we know, prescription drug abuse is a huge topic and is all over the news. And it seems like everybody is abusing controlled substances. But how many people are actually abusing? So in 2010, it was shown that there was 8.76 million people actually abusing controlled substances at that time. Now, this is a combination of painkillers, sedatives, muscle relaxants. And from 1999 to 2013, the years following when pain became the fifth vital sign. So pain became the fifth vital sign in 1990s. There was a period of time where doctors were afraid to prescribe controlled substances. And that was following Nixon, his war on drugs. He basically said, we need to fight this drug, this number of people abusing. And so he declared the war on drugs, and he developed the DEA, which was a federal regulation of the use of controlled substances. And also we had the Controlled Substance Act, which allowed for the categorization of these medications into 5 different categories based on their abuse potential and their medicinal use. So after that period of time in 1990s, there was a huge scare to prescribe controlled substances. So the American Pain Society said, we need to treat pain. All right, so they made it a fifth vital sign, and there were new standards of management of pain, and JCO made it so that doctors had to treat pain, and a lot of hospitals and physicians were scored on how well they managed patients' pain. So in 1999 to 2013, the years following pain becoming a fifth vital sign, the number of controlled substances that were dispensed and prescribed quadrupled. All right, and in 2013, there was enough controlled substances that were prescribed that everybody in this room, every American adult, could have a month's supply of hydrocodone taken every 4 hours. All right, that's everybody in this room with a month's supply. It's a huge amount of medication. So as you can tell, a lot of people became addicted to these controlled substances, and that was when we saw the birth of pill mills. Now, pill mills were seen largely in Florida. And a lot of patients will go into Florida to get prescriptions from doctors who made a lot of profit off of these pill mills. They will prescribe large amounts of these controlled substances to patients who did not have a legitimate use for them. And they will prescribe it to patients or people who were dealing these controlled substances, and they were willing to pay cash for these prescriptions. So these doctors made a lot of money. And if you can't go to Florida to get your prescription, you can doctor shop. Now, doctor shop doctor shopping is a felony in Nevada. And a lot of patients will go to several different doctors to get their prescriptions if they're abusing, or to get their prescriptions to sell. The consequence of this increase in the number of controlled substances that are prescribed and dispensed is that we saw a parallel effect in terms of the number of deaths. All right, so the number of controlled substances quadrupled from 1999 to 2013, and the number of deaths also was parallel. It almost quadrupled as well. To this day, there are 44 people who die every single year due to controlled substances. And there are countless numbers of hospitalizations and ED visits due to overdoses. And this graph here shows, again, from 1999 to 2013, as the number of controlled substances quadrupled, we saw a parallel effect, and that's the orange line, with the number of deaths associated with controlled substance use. So there is a correlation between the use of controlled substances and overdose deaths. We can't ignore it any longer. And a lot of times, people will use a combination of opioids and sedatives to get high, and a lot of times they can overdose. This chart here shows that in 2001, there were about 5,000 deaths due to prescription opioids. And in 2014, there was about 19,000 deaths due to opioids. All right, that's about 3.4 times increase. Now again, a lot of people use a combination of opioids and benzos to get high. And we also saw an increase in number of deaths due to benzos. So in 2001, there were about 1,500 deaths. And in 2014, there were about 9,000 deaths. That's about a 5-time increase in number of deaths due to these prescription drugs. The consequence is that in 2013, there were more deaths due to prescription overdoses than there were motor vehicle accidents or guns. And we saw that guns resulted in about 33,600 deaths, traffic accidents, 33,800, and overall prescription overdoses, about 44,000 deaths. This includes opioids and other kinds of overdoses. Among those who die from prescription overdoses, we usually think that is in the poorer inner city, right? We think it's the homeless, downtown Reno, the derelicts, right? The people that are on the street. But this problem is growing and is affecting middle class and upperclassmen. In 2013, they did an analysis of all the people who overdosed and died from controlled substances. And what they found was that the majority were middle-aged, Caucasian males living in the rural area. All right, so it is affecting not just, the homeless or inner city, it is affecting everybody. And surprisingly, a lot of kids are using controlled substances now, and it's starting at a younger and younger age. About almost 10% of middle schoolers and about 19% of high schoolers have used controlled substances within the last 30 days to get high. I mean, that's a huge number. And their reasons are, they're safe, right? I mean, they're prescribed by a doctor. Grandma uses them, my mom uses them, my father uses them. They're just in the cabinet. They're easily accessible. How bad can they be? They're not illegal. It's not like it's weed or anything. So they use these prescriptions and they get high, and addiction starts really young. So if you have kids, make sure you tell them that this isn't a safe drug to take. It is something that has consequences. It's highly addictive as the illicit drugs. So where does Nevada fall in all this? How bad is the problem in Nevada? It can't be that bad, right? Well, a few years ago, we were number 2 in terms of number of overdoses. We've dropped down to 4, which is great. We still have a lot of improvement, but West Virginia, Kentucky, and New Mexico are beating us. And Utah, surprisingly, is number 5. I used to live in Utah. That surprises me. So the deaths were lowest in North Dakota, South Dakota, and Nebraska. We know the commonly abused drugs, right? We have our opioids, our benzos, and our muscle relaxant, Soma. When used all three together, it's called the Holy Trinity, the triplicate. And a lot of pharmacies now that I know deny filling these three drugs in combination to patients. They'll either fill one or two and make the patient go to another pharmacy to fill the other. So pharmacies are taking action to prevent overdoses. Now, if you aren't obtaining these medications for pain or for abuse, a lot of times if you see patients obtaining all three, it's because they're trying to sell this. They're trying to sell these prescriptions because they're highly profitable. So this is just a chart here of what the cost of these drugs are on the street, and you can find this easily on streetrx.com. It'll tell you exactly the price you can get for your leftover oxy prescription, and it changes over time depending on the supply and demand. Let's look closely at oxycodone 30 milligrams. It goes for about $30 per pill, and alprazolam 2 milligrams that goes about $3 per pill. All right, so let's just say we get a standard 120 tablet of oxycodone, right, 30 milligrams. You pay about $180 to get that prescription. Depending on the pharmacy you go to, it may be a very good price, maybe a little bit higher for some pharmacies. But overall, so you get 120 pills, $30 per pill. That's $3,600 that you can make off of all of that if you don't take any of it, right? With alprazolam, just say you get 90 pills. All right, $3 per pill. You pay about $58 for the prescription. You're making about $270 off of that prescription. All right, and you pay about $25 for your copay. So your net earnings is $3,600 if you weren't to take any of those pills and you were to sell them. All right, that is more than probably any of us can make here in a week, you know, any legal drug dealer, correct? So it's highly profitable, you know, if you were to get these and sell them. And it's easy to sell them because you can advertise it even on Craigslist. These are actual postings from Craigslist that we found. Here on the top it says, I need to fill tank of oxy 30 milligram fuel. They're trying to be very cryptic here. Bone dry stuck on the side of the road, 200 Las Vegas. As you can see from my ad, I'm actually looking for some 30s to refuel me. I'm new to the area with my fiance. So they're basically saying, I need this, I have money, come find me. So the second ad here is Zanny bars, $3 on Tropicana and Jones. That's just a corner street in Vegas. It's not anything unusual. 2 milligram Zanny bars, so Zanny stands for Xanax. For sale, they're white bars, they're describing it. I have the brand name. Script is now higher. Hard to find since docs are getting busted, and that is true, so prices will go up. I will be raising prices soon. So people are targeting, you know, addicts on Craigslist. People are asking sellers to sell to them. So it's easy to obtain these prescriptions and sell them and make a huge profit off of them. And so as you can see, a lot of people are abusing these controlled substances, and doctors are now being held accountable for what they write. And here in California, I believe this was in March 2016, this year, a doctor by Lisa Sang, she was convicted of basically overprescribing and killing 3 of her patients. All of them were under 30, and they were traveling large distances to see her in California to get these prescriptions. So now she's been convicted, and she has 30 years in prison. All right, as much as we want to say this is not affecting Nevada, it is. We already talked a little bit about it, and that is Dr. Robert Rand. All right, he was arrested in April, just last month, as well as 8 others, and he's been charged with, you know, distributing these prescriptions and selling them and getting them on the street. But he's also charged with prescribing oxycodone to someone who overdosed, essentially, and he can face life in prison. Obviously, he hasn't been convicted yet, but it is something that has touched Nevada and especially Reno. So you think, I'm a pharmacist, I'm a pharmacy technician, I'm not accountable for any of this. Wrong. Just as much as physicians are accountable, pharmacists are accountable as well. Here in Montana, November 2014, a pharmacist by Benjamin Hun was giving extra pills and extra refills to a 24-year-old patient, and she ended up overdosing. Okay, he, a pharmacist, was convicted 4 years, right? 4 years in prison. And this Walgreens settlement, I'm sure you guys have heard about, basically Walgreens paid $80 million in settlement fines. It was the largest DEA settlement in history. And what they found was that the DEA found that a distribution center in Florida was getting large orders from 6 different pharmacies in Florida. And the DEA said that these pharmacies were dispensing these controlled substances for non-legitimate medical uses, and these pharmacies knew about it. And so Walgreens had to pay $80 million in the settlement fines. And these 6 pharmacies and this distribution center were basically restricted in what they can dispense, and they couldn't dispense controlled substances for 2 years. And Walgreens said, we will not compensate. We will not compensate our pharmacists for the volume of prescriptions that they are dispensing. So hopefully the take-home message you get here is that you as a pharmacist, you as technicians, you are the last line of defense. You are the gatekeeper to safety. You can protect the patient from themselves, and you do have this corresponding duty as a pharmacist to ensure that the prescription that is prescribed by a prescriber is for a legitimate medical purpose. So there has been a lot of talk about SB 459. So what is Senate Bill 459? Well, in the last legislative session in 2015, a couple of bills were signed into law to help this problem that we're facing, and that's the prescription drug abuse. And the SB 459 was spearheaded by Brian Sandoval, and it was signed into law May 5th and became effective October 1st of this year. And essentially what it did was it was signed into law to address prescription control substance abuse. So SB 459 covers 3 main topics, and that is Good Samaritan Overdose Act, all right? And it made it also that doctors are now mandated to run the PMP, obtain a report, and review it prior to prescribing a controlled substance to a patient. And lastly here, it made and changed the reporting requirements of dispensers to the PMP from weekly to daily, and we'll talk more about that. So what is the Good Samaritan Overdose Act? So the Good Samaritan Overdose Act actually increases the chance that a patient can get naloxone, right? It basically, we want to get naloxone out there so that if a patient does overdose, they can use naloxone, which is an opioid antagonist, to recover from that overdose. So now law enforcement can possess naloxone and administer naloxone based on this new bill. In the past, it was just EMTs and paramedics, but now law enforcement officers can, because they tend to be, first responders. They tend to be the ones that do encounter patients on the streets that have overdosed. So now law enforcement officers may administer naloxone. Prescribers now can prescribe naloxone to someone other than the patient, to the patient's friend or family member or caregiver, all right? And this is a huge departure from our traditional prescribing, which, a doctor must have a relationship with the patient prior to prescribing to them, and it needs to be prescribed to the ultimate user. So now a prescriber may prescribe naloxone to a family member to administer to someone else who are at risk of overdosing. Opioid antagonists now may be stored and dispensed by an unlicensed person as long as they're a standing order and as long as they dispense it without compensation. So this is our nonprofit organizations, addiction programs. They can actually possess it and give naloxone out to patients as long as there's a standing order by a doctor and as long as they do not charge for that naloxone. And lastly here, this is what will affect you most as pharmacists and technicians. Pharmacists are allowed to dispense opioid antagonist naloxone under standing order or protocol without an actual prescription. Now you have to follow a set of basically policies and procedures that are currently being written by the Board of Pharmacy, and I'll go over that in the next slide. So before you dispense, as a pharmacist or technician, before you dispense an opioid antagonist to a patient, you must first do a CE on how to administer or how to use the opioid antagonist, all right? Following that, you must follow standards and procedures or protocols developed and approved by the Board of Pharmacy, and you must provide training to a patient before you can dispense this medication to a patient. And the training includes how to recognize an opioid overdose, all right? And then how to administer an opioid overdose, okay? And what are the side effects after you administer the opioid antagonist? And lastly, the importance of seeking emergency medical attention once you administer the drug, because naloxone is very fast acting. All right, it works about 5 minutes, but it leaves the body fairly quickly, about 30 minutes. And a lot of times you need multiple administrations, so you may not have that, so or a patient may not have that. So it's important to seek medical assistance. So does SB 459, does it make you dispense naloxone? Does it make a prescriber prescribe naloxone? It doesn't. It doesn't. So you are protected by SB 459 if you feel uncomfortable with dispensing this medication, or if a doctor is uncomfortable with prescribing such a medication. You are protected. You are protected from civil and criminal, any administrative penalties based on SB 459. But if you choose to dispense naloxone, or if you choose to prescribe naloxone, you are also protected from liability, as long as you prescribe it and dispense it based on legitimate medical use. All right. So the law protects you from prescribing or not dispensing or dispensing. The law is extended to, everybody else. So if you are a drug user, or if you are experiencing an overdose, you can actually call for emergency medical assistance for yourself or someone else who's experiencing an overdose without actually facing any kind of penalties, without getting in trouble. A lot of times people overdose in the presence of others because people are scared. They're scared to call for help because they're afraid that they'll get their friend in trouble or themselves in trouble because they're associated with these illegal drugs. But they can't get in trouble for that anymore. And the reason is because we want to get people as much help as possible and to decrease the number of deaths due to overdoses. Now, the Good Samaritan Overdose Act is not new. A lot of states, the majority of states, have some law that allows for patients to obtain and get naloxone. And about half of the states, and now Nevada had joined in 2015, provide some immunity to doctors who prescribe it and pharmacists who dispense naloxone, and to patients who may call for help for themselves or a friend who is experiencing an overdose. Also, to help curb the issue with drug abuse, doctors are now mandated to use the prescription monitoring program. They're mandated to obtain and review the PMP report prior to prescribing a C2, C3, or C4 to a patient to ensure that the prescription is necessary and to ensure that the patient isn't getting the same prescription from someone else just a week ago. And they must do so if the patient is brand new to them, or if they have been seeing that patient years after years. If they decide to change the course of therapy, let's just say from hydrocodone to oxycodone, they must also check the PMP and query the PMP to ensure that there's a legitimate medical use. And the doctor must do that. They must obtain it and review it. And the reviewing must be done by the doctor, but they can delegate the task of obtaining the PMP report from the PMP to a medical assistant, to an RN, to the clinic manager, so that they don't have to actually do the legwork of pulling the patient from the PMP. A practitioner who violates the law, they may face professional disciplinary action from their board of pharmacy, if not from their board of pharmacy, from their licensing board, if their licensing board finds that the violation is intentional. Because doctors are now mandated to use the PMP, it's important for the information to be in the PMP and to be in the PMP timely and to be accurate. So SB 459 makes it now so that pharmacies, dispensers, and dispensing practitioners must report to the PMP database no later than the next business day after dispensing a controlled substance. So if I dispense a controlled substance today, I have until the next business day to report that to the PMP. This requirement obviously does not apply to controlled substances that are administered in the hospital or administered in the prison. And if you fail to actually upload this information to the PMP by the end of next business day on a day-to-day basis, you may be imposed with some kind of administrative penalties by the Board of Pharmacy. In the past, the reason why it was changed to daily reporting is because in the past it was weekly, and patients can see a lot of doctors and a lot of pharmacies and get a lot of prescriptions before there was any information or before anyone could put a stop to it, because there was nothing showing that the patient was receiving multiple prescriptions from multiple doctors. Okay, so that was Senate Bill 459. Now, Senate Bill 114 also pertains to the PMP and controlled substances. So Senate Bill 114 extends access of the PMP to law enforcement officials whose primary responsibility is to investigate prescription drug crimes. It also extends the access to the PMP to occupational licensing boards. And that's because the Board of Pharmacy and the division, we are tasked with reporting any suspected fraudulent activity to law enforcement officials and to the licensing boards of any practitioner involved in that fraudulent activity, so they can do investigations, so they can use the PMP and find additional information to determine if the doctor is engaged in any kind of unlawful or unprofessional conduct, and to determine if a patient is engaged in unlawful or unlawful conduct as well. So we talk a lot about PMP, and the majority of you, I'm sure, utilizes the PMP, but what is it exactly? So the PMP is a computerized program. So pharmacies that dispense controlled substances to patients, they submit this information to the PMP, and the PMP database houses all this information. All right. So once the information is in the PMP, it is accessible to providers and to pharmacists, so they can actually go into this database if they have a registration, and they can pull up a patient prior to prescribing or dispensing to the patient. And this access, again, has been is now available to licensing boards and law enforcement officials as well. And this database is available 24/7 and 365 days a week, as long as you have a computer and internet access and a sign-in. This is what a PMP report looks like if you all don't know. So here you see patient. The patient's name is patient 1234. The patient's information is on the top of the report there, as well as their date of birth and their address. And in the bottom part of the chart, we see all the prescriptions that the patient has been receiving. It has a lot of useful information, including the fill date, the written date, the drug that was prescribed to the patient, quantity, day supply, the prescriber, and the dispenser of that prescription. So as you can see, it's very useful. So if you were looking up a patient in the PMP and you saw that they just got 30-day supply of oxycodone a week ago and they're coming back in today, that would be a red flag. I would definitely call the doctor to ensure that that is actually a legitimate prescription and not a fraudulent prescription. And if it is a legitimate prescription, tell the doctor, have you checked the PMP? You're mandated to check it, and the patient just got 30-day supply just 7 days ago. So it's a very useful tool. And the second part of the PMP report is listed here. It just makes it easy to read. We have the doctors listed on top and the dispensers listed on the bottom. So the PMP is making quite a difference. 49 states have a PMP. Missouri is the only state that doesn't, and they really, really want one in that state. And so a lot of states now are mandating doctors to use the PMP, and New York and Tennessee are two of the states that do. In 2012, they mandated doctors to run PMP reports prior to prescribing to patients, similar to what had occurred in Nevada just this last year. And what happened was there was a 76% decrease in the number of doctor shoppers in New York and 36% decrease in doctor shoppers in Tennessee. So it does make a difference. Using it as a tool, you can find patients who are trying to abuse the system, trying to obtain multiple prescriptions for abuse reasons or to sell for profit. So as you can tell, doctors are now using the PMP and they're making decisions, prescribing decisions based on the information in the PMP. And so the accuracy of the information is crucial. The PMP information is as good as the information that is put into the PMP. But we have found some problems with some of the information, especially if you enter in the patient's name wrong. If you enter in the patient's name wrong, you can't pull up the patient then, right? And so the patient can go anywhere and get tons of prescriptions because their name was spelled wrong in the PMP and no one can ever really look them up. Another problem that we have, and a lot of doctors have complained about, is that pharmacists or technicians are choosing the wrong doctor when they're transcribing a prescription. So they may be choosing the wrong Dr. Smith from a drop-down menu or whatnot. But if they are attributed to a lot of prescriptions that they did not write themselves, they can face action from the board. So it's really crucial that the information is correct. And I've had to call off pharmacies to correct this information. It's crucial that when I call you or when the Board of Pharmacy calls you to make these corrections, that you make them as soon as possible and resubmit the information to the PMP so that not the wrong information is passed from one provider to the next. And we hired Dave Jones here to do a lot of the auditing of the PMP to ensure that the information is correct. But how does the wrong provider get selected for a prescription? Here's an example of why a prescription would be, a doctor will be selected, a wrong doctor will be selected for a prescription. Here's an actual example. Obviously, we changed the names of the doctors. So on the top of the prescription, we generally see a lot of doctors listed, right? We see John Smith, Jane Doe, who's a APRN, Susie Liu, and Nancy Johnson. Okay, there are 4 prescribers on this prescription. Who actually wrote it? Right. Okay, it kind of looks like a J. So, what was that?
Very white.
Well, it kind of looks like a J, so it could be John Smith or Jane Doe, right? But when you can't determine who wrote the prescription, it's important to call the doctor's office and ask so you can get the right doctor on the prescription. And the more times you call, they'll figure it out that they just have to write a little bit clearer or provide the DEA number, right? Here's another example. All right, very similar prescription, right? But who wrote the prescription? Johnny Apple, right? And it's very clear. It says Johnny Apple, MD. It has his license number up top. A lot of clinics may have a revolving door. There are doctors that go in and they work for a little bit and then they leave. So they can't change the prescription pad as quickly as they want to. So they may have an old prescription pad and that doctor's name isn't listed on that prescription pad, as you can see. But the doctor wrote his name in it. This is a legitimate prescription you can take. It is Johnny Apple that wrote the prescription, not John Smith. And that's what we had occurred. A doctor complained because that prescription, it had his name on top, just like John Smith, but his name was selected instead of the doctor who actually wrote the prescription. Here's another example. All right, we often see this. Again, several doctors listed on top of the prescription. The doctor's trying to do us a favor by circling the name of the doctor. They often circle 10 names at once instead of just the one doctor. And you have to choose, right? Which one is it? Do you guys know? No, right? Okay, and the signature doesn't help us either. So again, important that you call to ensure that you know who wrote the prescription instead of just randomly selecting, because doctors are complaining now and they don't want to get in trouble. To help us, hopefully, with this signature problem with these, these signatures are awful to read. Hopefully with the C2 prescriptions that can be transmitted electronically, as more and more pharmacies adopt this and as more and more offices adopt this and actually utilize it, we can actually know who actually wrote the prescription. So in December 2012, NAC 6397102 was amended to allow for electronic transmission of C2s to pharmacies. Now that's computer to computer, not computer to your fax machine at the pharmacy, right? And that computer system needs to be approved by the board. I put this slide up because this is a common question we get at the Board of Pharmacy, and it's the 14-day rule policy. All right, so what happens when you get a prescription that says do not fill until June 20th? Okay, when must that prescription be in your hand for you to fill it? Yes, it's 14 days after the do not fill date. All right, so if I brought in the prescription today and it says do not fill until June 20th, I can hold on to that prescription technically until July 5th, right? Because of that do not fill date. Okay, I just want to make sure everyone is clear on that because we always get that question at the Board of Pharmacy. All right, and a photo ID is necessary now for prescriptions for controlled substances that are being picked up. So whenever you are dispensing a controlled substance to a brand new patient or a patient you're not familiar with, definitely obtain their photo ID, make a copy of it, write their ID number, their name, either on the back of the original prescription or in the patient's profile, so you have that on record and is readily retrievable. Obviously, if you have a patient that has been seeing you for many years and you recognize that patient, you recognize that those family members of that patient, you don't have to ask for the ID. But if it's a if it's the grandson and you've never seen the grandson before, or their daughter picking up the prescription, definitely ask for their ID and have it on record. In the past, if they paid with insurance, you didn't have to request for the ID, but it has been changed that this does not exempt you from asking for the ID. I do want to say that you as pharmacists, you can decline to fill a prescription. I think a lot of pharmacists just feel that doctors put a lot of pressure on them to fill it, but you can exercise your judgment. If you feel that a prescription is fraudulent, or if you think that the prescription is not for a legitimate medical purpose, or that the patient can get harmed by using this prescription, you can deny to fill that prescription. Just know that you have that right to do so. And if you do find a fraudulent prescription, obviously report it to law enforcement. But I also want to tell you that we have this hotline report that you can find at the Board of Pharmacy website. And so if a patient brings in a fraudulent prescription and you noticed it and they notice that you noticed it and they don't come back, you can definitely submit a hotline report saying, this patient came in for a prescription that is fraudulent. I verified it was fraudulent with the doctor's office. When you submit that to me, what I do is I disseminate that to all the pharmacies in that area. So for Carson, I would disseminate that information to all of Northern Nevada pharmacies. So they know that there is this patient by this name trying to get away with these fraudulent prescriptions, so that if another pharmacy gets that patient, they are aware and they can call for, law enforcement officials. And that concludes my presentation.